Hi, I'm Kristin Larson. I'm a nephrology nurse practitioner, and I've been asked to speak at your conference, and I'm absolutely thrilled because I love the kidneys. Tonight is a beautiful day here in Utah, and I have got to sit on my porch and you get to look at my backyard here while I tell you some things about the kidney and hopefully just give you a few facts you didn't know. First of all, my disclosures. I am an employee of United Healthcare. I actually do house call visits and see persons with diabetes and early stages of kidney disease. I'm also a speaker for AstraZeneca, the pharmaceutical company, and I'm very involved with ANNA, the American Nephrology Nurses Association. So with that, let me start sharing my screen. Very good. Here are our slides. We're going to keep our kidneys kicking, kidney disease and renal health. I have my daughter Zoe here with me. She actually has renal disease too. She wanted to be part of the presentation. So let's get started. What are the objectives for today's talk? Well, I want to provide education about the importance of kidneys and diabetes. These really are married. Like salt and pepper, they go together, and really interventions to preserve kidney function. What can medicine do? And more importantly, what can you do as a person who has diabetes and may or may not have kidney disease also? I'll do a brief review of anatomy and physiology, some key concepts of kidney function. What does it do? What happens to the kidney when you have diabetes? That's really important because that's why you're listening to the talk today. And things that you can do to protect your kidney function. What is it that you can walk away with? Just even a few ideas to keep those kidneys throughout your whole entire life working as best as possible. I've got some key concepts here. These are my 4 favorite things about the kidney. Let me just move over my picture a little bit over here. First of all, the definition of chronic kidney disease. It's listed as CKD. And CKD, about 20 years ago, when I started as a nephrology nurse practitioner, really didn't have a classification system. It was just kind of all over the place as how you described having kidney disease. Now we actually do 5 stages. So stage 1 is minimal change in kidney function. Actually, the kidney function can be practically normal. There's just some things, some laboratory tests that aren't quite right. Or stage 5 kidney disease, and that requires dialysis or transplantation. So you can see you've got a wide gamut there. Most people don't reach stage 5. Hopefully we can hold their kidneys in a stage 1 through stage 3, which is what I try to do for a living, keeping them there. How do you diagnose chronic kidney disease? Well, it's diagnosed in blood and urine and also symptoms. Your blood will definitely tell you if your kidneys aren't working, and that makes sense because your kidneys aren't doing their job of filtration. Your urine can have some telltale signs that it's not working and it's not having the proper toxins inside of it. Also, too, if you're not urinating at all, that's a problem. And then there are symptoms with kidney disease, and as the kidneys progress in disease states, they just don't clean the blood, and those are manifested in symptoms that we see in people such as fatigue, sometimes loss of appetite, profound itching, sadness, depression. That's a whole nother talk, so invite me back for that one. Active participation by the person with CKD can halt or slow the progression of kidney disease. I cannot stress that point enough, that your kidney disease, it really requires self-management. You can get all the great advice from healthcare professionals that you want, but if you don't translate it into daily life, you're not going to see a healthy outcome for your kidney. So know that just like with your diabetes, kidney disease also really requires your participation. And that's actually one of the things I try to do when I'm seeing my patients, is encourage them to be active participants. Then we have something called glomerular filtration rate. It's referred to as a GFR. And this is the measurement of the kidney function, and it's rated from 0 to 100%. That's how I like to think of it, 0 to 100%, or it's in milliliters per minute. When you look on your chart or your laboratory values and you'll see GFR listed, it's usually in milliliters per minute, not so much percentage. The percentage of GFR equals the stage of kidney function. If we're looking at stage 5, that's usually about 15% kidney function or so. Stage 3, somewhere in the middle, is about 60 for the GFR, or 60%. Stage 1 is anywhere from 90% to 100. So the percentages really help us fall into that GFR calculation. And then that brings me to, it actually is a calculation that's based on your laboratory values. And I actually have the little computer program on my phone. So I plug in everybody's GFR to see where they are so I can do that proper education. Most persons with diabetes do not need dialysis until their GFR is around 15. So if you're born with 100% or more, you've really got enough, hopefully, to last you through your life. The next one I want to talk about is creatinine. Its initial is CR on your laboratory value. That's found in the blood and it's found in urine, and it reflects the muscle metabolism of your muscle cells. So actually the metabolism, the daily process of living of your muscle cells, because your muscle cells secrete creatinine. And actually what your creatinine is as a young person, let's say 20s or 30s, is pretty much what it is as an older person. That carries you through to your whole life. My creatinine is 0.7 and I'm 59, and it's been that way since I've been tracking my labs. A rise in creatinine, however, can indicate a decrease in kidney function. And that's because the kidneys just aren't filtering the creatinine into the urine, and therefore the creatinine level is rising in the serum, in the blood. The last one is blood urea nitrogen, and that's listed as a BUN. Not a bun. Don't call it a bun. It's a BUN. And it is an increase in a BUN can indicate also a decrease in kidney function. This is really more a reflection of the protein that you take in, because it's blood urea nitrogen. Anyway, take these four concepts: CKD, GFR, creatinine, and BUN, and bring up your labs and see what they've been running, and actually see what they've been trending throughout the years. That's really the best indication to see how are your kidneys doing. I'm going to get myself a little bit situated a little bit better here. There we go. Oh, come on. Move to the next slide, please. Here we go. Let's talk about anatomy and physiology. It's so cool. I just love the kidney. It's like, it's the coolest organ ever. It's made up of something called a nephron, and there's about 1 million nephrons in each kidney. Think of a nephron as a straw. I actually kind of like to think of a nephron as one of those curly straws like children like to sip their sodas through. It's got a lot of loops and fun things in it, and all of these nephrons are then surrounded by beautiful blood vessels. I like to think of it as a lace of blood vessels, which is why the heart gives about 20% of each squeeze, each pump, just goes to the kidney. And that might not sound like a lot, but if you think of it, the kidneys are the size of your fist. They're this big, and there are two of them. Actually, the right one's a little bit lower. That's because the liver's on top of it and it pushes it down a little bit. And they weigh about 1/3 of a pound. So you've got this organ that's less than a pound, and it receives 20% of the blood flow from your heart. That's amazing. The other 80% of the blood is going throughout the body. So they are a very, very, what we call vascular organ. They are blood rich. Interestingly enough, here's your fun fact for your trivia pursuit. It's formed, your kidneys are formed in your first trimester of life, which is also when your ears are formed. And if you think of it, I think your ear and your kidney kind of look alike. They're kind of the same shape there. They're kind of this round shape like you see over here on the picture. And about 1 in every 500 to 1,000 people is born with a single kidney, or they're born with one kidney that's just small and immature and never grew in utero. So the only way that that's found is if you actually were having like an abdominal procedure, or you had a CT scan or something like that, that actually looked to see, my gosh, you're missing a kidney. So I've had people tell me that they didn't know it, or you can go to your grave with just a single kidney. Remember, you have an heir and a spare, as I like to think of it. So that's why you've got two. The main functions of the kidney are the excretion of body waste. It's meant to get rid of toxins, and it gets rid of extra fluid, and the urine is what carries those toxins out. It's like a 24/7 cleaning. It's a 24/7 dishwasher that's forever got that water going, which is why your bladder constantly fills up. It also monitors, regulates, and keeps in balance your electrolyte and your minerals within your body, which is really important because you don't want those going askew. Your body doesn't like that, especially your heart. And the kidney is also an endocrine organ. It produces hormones that alter your blood pressure, your red blood cell formation, and vitamin D. The very last part of vitamin D synthesis is done in your kidney, which is really important because vitamin D is part of your bone and mineral metabolism. But it does so much stuff for being this little guy that's only the size of your fist. And I just think it's just so cool. And I hope you think it's just super cool too. What's the pathophysiology of diabetes in the kidney? Well, diabetes is a disease of small blood vessels. And you can see my 4 pictures over here. Eyes, kidney, heart, and toes. Yep, people with diabetes lose toes. It's because those are tiny vessels. Okay, what did I say about the kidney? It's wrapped, those nephrons are wrapped in a lace of fine blood vessels. So it's a small vessel disease. About 20 to 40% of persons with diabetes will develop something called diabetic nephropathy. That is a specific type of kidney disease that's diabetes related. And as you can see, not everybody develops this, but a good, maybe almost half of people do. And I want to say as the incidence of diabetes increases, and especially the people that I see who do not take active participation in their diabetes management, those people, yes, they do have kidney impairment. They have nephropathy. Diabetes is the leading cause of end-stage kidney disease or end-stage renal disease, which requires either dialysis or transplantation. When you get to the very last function of your kidney and it cannot monitor your fluid and your electrolyte balance anymore, you have limited choices, and they are to go on dialysis or receive a kidney transplant. And as we talk about healthcare disparities that have become so prevalent over this last year, as compared to white Americans, African Americans, Native Americans, Hispanic Americans, and persons of Polynesian descent have far more about diabetic kidney disease than their white counterparts. So we've got some work to do. What's some more pathology here? First of all, I want to bring you to the picture over here of the gold, kind of the gold cup. That's the end of the nephron there. And then the squigglies inside there, that's the blood vessels. This is my favorite part of the kidney, and it's called the glomerulus. And I like to think of the glomerulus as like a bouncer at a bar, if you've ever been to a bar, which I have been. Anyway, a bouncer lets certain things in and certain things don't come in. That is to the bar. Well, a glomerulus is kind of the same concept. It lets certain things pass through to become part of the urine, and it keeps other things out which should not be in the urine. So it's the first part of the nephron, or I like to think of it as the first part of the kidney, and it's really an incredibly important part. When you have hyperglycemia, too much sugar in your blood, it basically causes injury to the cells of the nephron, in particular the glomerulus up here, that gold cup. The hyperglycemia causes the blood pressure changes in the first part of the nephron called the glomerulus. In other words, there's a blood pressure change and the blood pressure increases. And the blood pressure increases because it senses this super sweet blood coming through, and it says, wow, this is not normal. I've got to pump it up. I've got to get bigger to try to accommodate the cleansing of all this sugary blood. And it can only do this mechanism for so long, and then the glomerulus says to heck with it. This, as I said here, the protective mechanism can only work for so long, then it stops working over time because it's exhausted. Just like this picture of this man here. He's exhausted, he's overworked, and you all know that feeling in your body when you're overworked. You just can't do it anymore. Okay, so your glomerulus is the same way. The blood pressure changes from the increased blood pressure cause injury and scarring to these super fine blood vessels, the red part there, and then it causes scarring within the whole glomerulus. In other words, it hurts it. It scars it, so it's never going to be the same. And if a glomerulus doesn't work, you are going to see changes in your urine. Let's go to that one. So how do you screen for kidney disease in persons with diabetes? The most common laboratory abnormality of diabetic kidney disease is persistently elevated albuminuria, also called proteinuria, which is the leaking of protein into the urine. The glomerulus should not let albumin/protein, we're going to use those terms interchangeably, into the urine. The bouncer's falling down on the job because it's scarred, it's overworked, it just can't function anymore. Another way you can tell that you have kidney disease is that you have a persistently decreased estimated GFR, meaning that the filtration percentage of your kidneys is going down. You're going from that 100 to the 60, and you're going even further. And as that GFR declines, so does the efficiency of the kidney. You can have one or you can have both. Oftentimes I see both. The American Diabetes Association recommends annual testing of blood creatinine level, a GFR calculation, and urine albumin levels. These are things that you as persons with diabetes should absolutely know. Have it on a spreadsheet. I'm a paper girl. I write all this stuff down on paper because I want to know. Abnormal results should prompt repeated testing in 3 to 6 months to confirm whether the initial screening results were abnormal. One test does not diagnose you, but we're going to follow up on it. And hopefully your providers, your physicians, nurse practitioners, PAs are following up on this and looking at it in 3 months, looking at it again in 6 months. And if you see that trend, you see that tracking, yeah, the bells and whistles should go off for you probably have kidney disease. And let's grab it before it gets out of control. And that's why I have a bell and whistle here. So the albumin to urine creatinine ratio, the ACR, has been around for quite a while. It's been around as long as I've been in nephrology, for 20 years, but has really, really gained probably the respect and the insight that it deserves within the last couple of years. An ACR is the albumin concentration compared to the creatinine concentration in a spot urine sample. That's where they give you the cup and say, give me a sample. It doesn't need to, nothing special has to have gone on. You're just peeing in a cup and we're just gonna take a look at what does your urine look like at this moment in time. Albumin, as I said, is a type of protein and it should not be in your urine. And then if you do have albumin, it's actually listed in 3 different levels. So the results are listed as no or low to albumin, moderately increased albumin, and severely increased albumin. I get excited over all of them, and that's because I'm a kidney nurse. So look on your labs and see what your ACR is listed and what's the number behind it. So are you then the less than 30? Or are you the 30 to 300, which is kind of that middle ground? Or are you over 300? Why is this such a big deal? This is a key point for you guys to walk away with. This is a big deal. Severely increased albuminuria, now they're saying anything over 300, has a worse prognosis of kidney disease. So your GFR can actually be at 100%, but you're spilling protein. That's not normal. And because of that, if you do have albuminuria, you are at an increased risk for developing end-stage renal disease. They have found with the people that have had albumin that's been spilling for years, those people progress to end-stage renal disease far more than individuals who don't have albumin in their urine. And also, you see cardiovascular events. That's a heart attack and that's a stroke that has an increased incidence when we see albumin in the urine. So this is a big deal. Please know what your ACR is, your albumin to creatinine ratio. So let me recap my criteria. To recap, in most persons, now there's always that one aberrant person, but in most persons, the persistence of albumin in your urine excretion greater than 30 and or a GFR less than 60 for at least 90 days confirms some type of kidney disease. And I will actually have you get on, I'm not endorsing any site, but I do like NKF, and that's nkf.org, and that has wonderful information on kidneys. And they will walk you through the stages of CKD. One screening, as I said, does not diagnose diabetic kidney disease, but having diabetes, either type 1 or type 2, does put you at an increased risk. And the good news is not everybody with diabetes has kidney impairment. So I want to have a heightened sense of awareness here, but I don't want anybody just, oh, freaking out. Kristin said, no. Kristin said you're gonna go in this as an informed healthcare consumer. Okay, diabetic kidney disease progression needs active participation by you. You're part of this group, so you're already actively participating. Good for you. Diabetic kidney progression, as I said, is different in all persons. And really, they believe that there is actually some genetic component to this. Right now, we can't swab your cheek and look at your DNA and tell you how fast you could progress if you've got a diabetic kidney disease or not. But I really believe that, and I also believe it's familial. If one person in the family has diabetic kidney disease, I tend to see it in groups. That's one of my questions that I always ask when I'm seeing somebody with diabetes who's got kidney disease is how many other people have this in your family? Without medical intervention and active participation, a person with severely increased albuminuria will on average progress to end-stage kidney disease within 6 to 7 years. That's a person who doesn't treat this. So you can see you really lose a lot of that nephron, a lot of that glomerular function very, very quickly. The faster decline, as I said, is seen in higher levels of albuminuria. You're hearing that word again. Elevated A1C. What's elevated for you? And I'm not even going to go over what's normal because everybody's different on that one. Elevated systolic blood pressure. I really like my pressures, 130 over 80. I can live with 140 over 90. After that, I start having hypertension. So actions to keep your kidneys healthy can be assisted by good life choices. And there's actually a salad. And I have insulin resistance. So I think I need to join your group. I'm not diabetic, but I'm insulin resistant. And I have really, really modified this summer, taken an active hold on that. And since I've checked out your website, really modified my eating. I now meal prep before I go to work. I didn't think it was so possible to eat so many vegetables in my life, but I'm really finding that they're pretty good. So no more sandwiches for me. We're going healthy protein, healthy veggies. Keeping your A1C at goal. Okay, the benefit of strict glycemic control should not be underestimated. You have the power to do this. So whatever is the recommended glycemic control for you, and as I said, I've read publications somewhere around 7. That's really where I like to keep my people. However, everybody is different, so that's individualized. That's your individualized plan of care. Control of sugar slows the onset or progression of diabetic kidney disease. Absolutely, positively. For the most part, yes, it does. There is always that person who has done everything right and they still progress rapidly and we don't know why. There again, that's where I'm thinking there's a genetic component. One of the questions I do get asked is, Kristin, I've been told if I have kidney disease, I'm supposed to limit my protein. And I just had to put this in here because there is no firm evidence to show that dietary protein restriction slows the progression of kidney disease in patients with diabetes. So with that, you are to follow your instructions from your diabetes educator, your diabetes dietitian, and eat the protein amount that's recommended for you. Don't stop it and don't go overboard on it. What's just right for you? Albuminuria. I've talked a bunch about this, and what I haven't said is, well, what can I actually do about it? Okay, there are medicines called angiotensin converting enzyme inhibitors. They're ACEs, or angiotensin receptor blockers. Those are called ARBs. Help decrease albumin in the urine. These would be things like lisinopril, ramipril, irbesartan, valsartan, candesartan. Go and actually Google this and figure out, are you on one of these medicines? They really, really do limit that, help curtail that albuminuria, and the physiology is right there at the glomerulus, where they work, which is where the leaking of the protein occurs. These medicines, I always tell my people, this is a 2-for-1. So when I pick up the bottle of lisinopril, which is actually the most common one that I see, I say, first of all, this must be for your blood pressure. Yes. And then I always say, have you ever been told that it protects your kidneys? It puts a little force field around those blood vessels, those superfine lace blood vessels of the glomerulus. It puts a little force field around there and actually protects them. So you're getting the benefit of 2 medicines for 1 here, which is why please don't decide you want to take yourself off this medicine unless you've talked to your doctor, your provider, your nurse practitioner, or PA. It reduces the pressure of the glomerulus, as I said, thus reducing the stress and the scarring and the subsequent albumin excretion. So I love them. Nephrology loves them. That's our go-to drug, our ACEs and ARBs. There is a strong association has been found between decreased albuminuria, proteinuria, and slowed progression of kidney disease and the eventual risk of end-stage renal disease. This is really one of your take-home points. The benefits of just this medication, or these medications, these classes, really cannot be understated. So please don't skip this if you're taking them. Things you can do to preserve your kidneys. Okay, what is a take-home message? What can I do here? This is gonna go on my tombstone. Kristin Larson talked about NSAIDs, non-steroidal anti-inflammatory drugs. This is the ibuprofen, naproxen, celecoxib, as well as the brand names that go along with them that I don't know if I can say those or not, but you can figure those out. Anyway, if you take these medicines, your doctor, your nurse practitioner, your PA, they need to know this. When I was in nursing school in 1985, these drugs were prescription, and you saved up all your meal coupons in the dorm, and you exchanged the meal coupons with the girl who had the bottle of ibuprofen, because they are so good at reducing pain, which is why people love them. I don't negate that. However, the best analogy I can use is they're like battery acid going through that glomerulus, not to mention the fact that they can also lead to gastrointestinal bleedings, bleeding in the bowel. So they're not bad medications. They just need to be used with the utmost of respect when you have kidney disease. So if you can take Tylenol or acetaminophen, rather, the generic name, that might be an option, or other options for pain relief. But please let your provider know that you're taking NSAIDs. Be honest about how much you take. I had one patient who I leaned in and I said that, tell me what you're taking. She was taking 16 200 milligram tablets in a day, and I just laid my hand over my heart and just said, okay, we've got to come up with a different plan, because not only are you going to spring a leak in your gut, you're really going to do some damage to your kidneys here, and just way too much. This was meant to be a drug that you took intermittently and rarely, not on a daily basis. The next drugs I want to talk about, or rather next supplements I want to talk about, are your dietary supplements. And I just gave a talk on this because I'm amazed at the amount of dietary supplements and the supplement within a supplement that are taken by people and never relayed to your provider. And half the time it's nobody's fault. You didn't have time, or no one asked you. I challenge you that the next doctor visit you have, that you actually bring that bag in, and if it's a box, a shoebox, or bigger than a shoebox, I've seen bigger than a shoebox, bring it in so your provider can see absolutely all of the herbals and supplements and over-the-counter pills, potions, liquids, things that you take, just so they know, because there are interactions and you can actually overdose on this. Absolutely. So be smart about your dietary supplements, and also to what they're doing to your kidney and or your blood sugar. Cholesterol and lipid control, that's not just taking care of your cholesterol within your bloodstream, that's stabilizing the plaque there on those arterial walls. So that is very important too. Nutrition, I love doing my house call visits when I go into people's homes, because I prefer not to sit in the living room. I want to sit in their kitchen so I can pan the countertop and see exactly what are they eating. And if it's ramen noodle and Rice Krispie treats, we have a problem with nutrition here. And maybe this is why your A1Cs can't get under 10, and you've got other issues, your hypertension going on. So really look at what are you eating. You've got lovely resources on this organization to help with that. Nutrition counseling, there's just options. And I like to say, it needs to be picked from a tree, come from a bush, or pulled from the ground. Absolutely. I always have a vegetable that's above the ground and below the ground with every meal. So I make sure I have enough greens and good stuff like that. Healthy lifestyle, that would be exercising. And I find often that is the hardest thing for me to have my patients to do. And oftentimes we have to just start small. Can you walk from your house to the mailbox? And for some people, that's all the activity they do for the day. And then after that, if they can do the mailbox, can they walk around the block? You physically need to move your body. The fastest way to die is to sit in a chair all day. And I'm asked every week by somebody, isn't there a pill that I can take that's going to make me feel better? I said, yes, it's called Vitamin Walk. You need to move your body. Walking is good. You really will feel better. If nothing else, the house will just take over if you just sit in the house all day. And then finally, no smoking is a no-brainer. I just can't even believe that people still do it. If nothing else, how can you afford it? They are expensive. And finally, these are your take-home points. Okay, know your number. Serum creatinine and BUN. One of the things I want you to look at is how has the number changed over the years? Just like if you're looking at a scrapbook, one set of pictures doesn't tell a whole story, but a whole scrapbook does tell the whole story. It's the same with serum creatinine and BUN. How have these changed through the years? Are they about steady? Or do you see that serum creatinine start to rise? Do you see that BUN start to rise? The first thought I would think of is there something going on with the kidneys? Has it been fairly stable? The next thing to ask is ask your provider, what is my GFR? And you can actually find GFR calculators, and you can put in the constituents, the blood levels that they want. There's multiple different calculations out there. There again, NKF, I'm not endorsing, but that's the one I use. Has a couple different programs out there, but it's actually calculated. You can plot your own GFR. Oftentimes on your laboratories, the GFR is listed as above 60 or less than 60. Know what your number is and track that too. I just saw somebody today, this morning. I saw patients this morning, and she says, wow, they just took me off ibuprofen. I have a little bit of kidney disease. And so I pulled up her labs. She had 10 years worth of GFR going down, just a little bit, a little bit, a little bit, a little bit. So she finally hit the bells and whistles area where, wow, you're dropping below a certain number. She was actually below 60. And she was angry. She said, why didn't anybody ever tell me? And I said, I'm sorry no one ever told you. But I'm here today, and this is what we're going to do. And we're going to start tracking this. And these are some healthy things for your kidneys. And the first thing is the ibuprofen's got to go. Got to go. She wasn't happy about that, but she's even less happy about having kidneys that she didn't realize were slowly declining. So know what your GFR is. Once again, and I put that on the bottom there, you're fine. Do not take your fine for an answer. You actually want a number. If you have a decreased GFR, come right out and say, do I have CKD? And if so, what stage? Yeah, they'll plot it. If you have the numbers yourself, you can do your own work. You can do your own legwork to find out where you are in that CKD stage. Ask if you have protein in your urine, because remember that is one of the biggest indicators of progression to end-stage renal disease, as well as cardiovascular mortality. You need to know if you're dumping protein. And if so, how much? And then what type of medication are you on? Are you on an ACE or an ARB to protect that? And once again, your fine is not an answer. And I hear that a lot. And that just really dismays me, because no, I write down exactly where they are, what they're doing, because I really want to make people kidney smart. You know, my dream is that one day the commercials during the football games are going to have, you know, do you know your GFR? Because right now there's lots of medications out there for blood pressure, diabetes, erectile dysfunction, and depression. Let's throw kidneys in there too and make them just as important, because they are. And what's the next slide here? And finally, that's a picture of me, my name, and my email address if you have any questions. This is just the beginning of kidney, and I could literally talk on this all day. So if you want any more information, please have me come back. I'd love to speak to you. It's truly a passion, and such a pleasure to be invited to speak at your organization. So thank you much. Bye-bye.